Right, I'd like to welcome you to Eye Contact, a video news programme on the issues and controversies in ophthalmology, sponsored by EUROTIMES. I'm David Spalton, and we're going to talk about hard cataracts, which are a difficult clinical problem, Brian. Brian works at Moorfields Hospital and has a lot of experience in handling complicated cases. Brian, what do you think is the major problem in dealing with hard cataracts?
Well, I think there's quite a few problems, but you sort of have to break the complexity down into simple steps, really.
Yeah.
And I think to start with, you must lower patient expectations because of the high complication rate you get with these cases, PC tears and dropping fragments, etc. But as far as actually the sort of preparation for the cases are concerned, the biometry can be difficult penetrating hard cataracts, less so now with the sort of latest generation of optical biometers. But I think in preparation, I think it's lowering expectations from a patient's perspective and being fully prepared for the surgery in terms of the devices that you have available to you and the techniques that you're going to use.
Yeah, these are cases with a higher rate of complications, you point out. Do you think they should really be done reserved for experienced surgeons?
Absolutely. They're always difficult cases. They're never straightforward. And you need a significant amount of experience to be able to confidently deal with the problems that you inevitably are going to face with them, really.
Do you see many really dense cataracts coming through these days? In my practice, they're quite rare now.
Yes, I think they are rare, relatively, in my practice as well. I do some work with Orbis, the International Eye Charity, and of course you see it much more in developing countries, where it's much more of a challenge.
Yes. So when you come to do the case, what are your tips for when it comes to the actual surgery that you're going to do?
I think the best tips I can offer are anticipation, planning, preparation, really, and that you've actually thought very carefully about how you're going to approach the case and the problems you might encounter and what strategies you've got to deal with them when you meet them. Because during the surgery, for instance, these cataracts are often in elderly folk who also have significant zonulopathy or weak zonules and wobbly lenses. The capsule is unpredictable, and the capsule can be a thin, diaphanous capsule, or it can be tough with subcapsular fibrotic plaques. And
it's quite an important point, because I sometimes think these capsules, these very rock-hard cataracts, are quite brittle.
Very much so, I think. They're thinner. And of course, you're inevitably using vision blue, which actually lowers their elasticity. Because although it doesn't actually reduce their tensile strength, they are less elastic, so tear more immediately when you apply traction to them. And I think you need to take a great deal of care during the exercise to avoid problems.
What about your technique? What sort of phaco technique do you like to use with these cases?
I personally use a stop and chop technique. There are a number of techniques available, and I think you've got to choose what is safest and most efficient in your hands, and for me it's definitely stop and chop. And I think the greatest tip that I can offer and that I've learned over time is to make sure that you go deep enough centrally with the initial groove so that you can actually propagate the fracture right through the posterior plate, which is one of the toughest parts of the cataract in these cases.
And sometimes you can end up with a sort of petalloid appearance of the cataract, can't you? Which can be very difficult to deal with.
Yes, absolutely. And I think you actually just stick to the principle of shaving down centrally and deeply, bit by bit. And the mistake that's often made with the technique is that people tend to use the phaco-tip as a gouge rather than passively let the phaco-tip do the work and have the right settings and use enough energy and go slowly and take shallow bites at it as you do it. And then you can progressively deepen it to the point where you're about 90-95% of the way through, and then it will fracture very easily. But you need to go that deep.
I was going to come on to what's your advice about phaco settings? What do you like to use for that?
Yes, personally, my settings are fairly fixed, and I use the sort of the variability I leave to using the pedal, so that my settings for phaco are set on 95% power, and my bottle height's up at about 90 centimetres, so that I have linear control of the power I'm going to use. But for these settings, you particularly benefit from having modern power modulations, so that using pulse phaco and also torsional phaco has really revolutionised much more easily you can approach these cataracts.
Because of course you don't get the problems with wound burn.
No, absolutely.
In that situation, and with high phaco powers, that used to be a big risk. Didn't
it? Of course, I mean one of the commonest problems we had with them, with wound burn and certainly corneal edema during the surgery. But it's nice to use a combination of torsional and longitudinal, because with these cataracts, they can clog the tips, and with a proportion of longitudinal phaco, and that tends to minimise the risk of that happening.
And with these cases, by definition, you're using lots of phaco par. What do you do to protect the endothelium?
Well, you
viscoelastic-wise.
In viscoelastic-wise, just use dispersive endothelium or one of the lower molecular weight hyaluronic based ones, and that, because we know that the endothelium has these receptors for low molecular weight hyaluronic acid, and so using something like Viscoat that will give you some added protection of the endothelium in these cases, because your phaco times are inevitably long and you are using high power, so the endothelium is of course at risk in those cases.
Do you think there's any advantage in soft shell techniques? Is that a thing you...
I don't particularly think soft shell. I think the part of the soft shell that's useful in these cases is the dispersive viscoelastic that you're using in the endothelium.
Yes.
And actually during the removal of the nucleus, I think it's very important to confidently and completely separate the fragments so that they're fractured through right to the sort of posterior plate, because then they're mobile and they're easy to remove in that case. And
I think one of the problems sometimes with these very hard cataracts is you've got very little soft lens matter there, so that you go right up to the capsule with really hard material.
Well, you do, and I think one of the most useful signs that I've learned to appreciate over the years has been the appearance of the epinucleus in the base of the cataract as you go through the central nucleus and you're coming out the other side, as it were, and you get a very consistent change in appearance of a white, reflective, mother-of-pearl appearance of the base of the groove, and that occurs when you're about 90-95% of the way through, and it's an immensely useful guideline to give you so that you know when you're far enough down to be able to fracture it.
There are some surgeons who think that it's probably safer to do extracapsular surgery on these. Is that...
I think it's whatever is safest in your hands. I think if you're inexperienced at doing phaco and you come across these cataracts and you have some experience of doing extracapsular surgery, then that's going to be the safest option for you.
Most of us don't, of course, these days.
Exactly. Well, it's an ever-increasing problem, isn't it?
Yes.
Yeah, it really is.
Yes.
So that I think, but you can approach these with the manual small incision technique, of course, just using a scleral incision, a wide-based scleral tunnel, a large rexus, and then you can actually prolapse the hard nucleus out and get it out of the eye on a manual technique.
And then finally, what do you think about femto surgery, femto cataract surgery for this sort of situation?
I don't think it has an important role in these situations. The one area where you may consider using it is for the capsular rexus, which can be challenging. But I don't think it plays a major role for these cases.
Yeah, good. Well, Brian, thank you very much. It's very kind of you to join us and share your experience. If you'd like more information on this or related topics, please visit us on EUROTIMES.org. Thank you very much, Brian.
Thank you.